Friend Doris Thecoder back with another video. If you are new to my channel, welcome. If you are just coming back, well, welcome back. As a consultant auditor and educator, it is my goal. One of my visions or passions is to bridge the gap between clinic speak and code speak. Clinic speak what the providers say, code speak what the codes say, and the guidelines and all of the guidance that go with that. Before I forget, if you want to be notified on when I post and stay abreast of everything I'm doing, subscribe to my channel, comment, like, give me your feedback. I really do use it. I am so excited for this session. This is my very first dialogue with a doc session. This is something I've been doing for years, but now I'm actually doing it with providers, publishing it, and putting it out for you all to learn. Today's session, we're going to talk about critical care medicine, and I am so excited for my first guest speaker. Dr. Tamara Beckford. I'm going to link her information in the description box. She is a busy professional with beautiful energy and wears many hats. She's a board certified practicing emergency medicine physician in Houston, Texas, a wife, a mother, and if all of that was not exhausting enough and made you exhale forcefully, when she isn't responding to code blues in the ER, she lives her passion as CEO of You Are Caring Docs and You Are Caring Society. You Are Caring Docs and Society supports and empowers other professional women in their wellness journeys by helping them take an active role in putting themselves first for 2 hours a month. With that, it is my pleasure, it is my privilege, and quite honestly, a prayer answered to welcome my mentor and a person I am coining the friend I haven't hugged yet, Dr. Tamara Beckford. Again, I'm going to add her information in the description box if you want to follow. And with that, I will stop talking because the gold is going to come from our wonderful, warm Dr. Tamara Beckford. With that, Dr. Beckford, please come right in. The vision of this was to talk about critical care. Now, critical care is one of those services that, as a provider who performs it, there is a misunderstanding between how they wrote the codes for critical care from an intention standpoint to what providers think it is. So there's two criterias that we look to apply in critical care. And my coders look for example, the condition. And the condition, I think, is depending on what the condition is, can be the easiest thing to find, but can also not so much. If we see, liver failure, renal failure, heart failure, things like that, it's very easy to say, yeah, no problem. We know that's critical. That's a vital organ system. Where the condition gets difficult is when it's one that is not yet, but potentially can be. So we see a hematocrit of, I don't even know, what is a normal?
Hemoglobin. Yeah, like you're right. That's the challenge with critical care. Even from the physician standpoint, it's still challenging to look and to say, well, is this critical care or is this not critical care? Because one of the two criteria, one is this is happening and you are treating it, and then the second part is it's inevitable and you're preventing it. And that's, I think, where the challenge lies with you see it's being inevitable, like it's about to happen and you're preventing it by intervening, and then but showing all the reasons as to, hey, this looks like this is going to happen. It's hard to show it on paper or on documentation when you are in the room and you're like, oh wow, this patient's about to crash. You have to give this now, because even though these numbers look this way, you can see either through experience or through gestalt, the art of medicine, which is different than the direct science of medicine, and like something bad's about to happen, you have to intervene right now. And that's, the challenging part of that critical care documentation.
Yeah.
Yeah.
Yeah. And that's where I think we have the biggest issues when I think about the vision of this, because some providers, I've had a patient with a finger abscess be documented as critical care. Just
Mhm.
again, and one that I thought was, that one's probably a little more obnoxious, though factual. I had one where, and I could kind of get what the mental work of the provider was. It was a
Mhm.
patient who was status post an intracranial procedure. And as a
Mm-hmm.
result, the provider felt like, listen, this is why I thought it was critical. And her rationale made sense for me when I thought about what she was thinking about. She said, there is a high risk. These patients
Mm-hmm.
have to be watched very frequently. So when we go back to those two criteria I look for, it's the condition criteria and the care criteria, the what you did. The
Mm-hmm.
patient's condition was such that they were kind of baseline. They were breathing on their own. They were being watched quite frequently. Like they had to watch them
Mm-hmm.
very often because she's like the intracranial pressure can increase. And if that happens, all of the things that could come as a result of that. But when I looked at the care part of it, I'm like, okay, even if I don't question the condition part, there was like as needed Tylenol, elevated head of bed, neuro checks every like 30 minutes or
Mm-hmm.
every hour or something like that. And the patient was inpatient. So, of course, that's done by nursing. And looking at it, it gave me pause. And I'm like, so I understand the level of its intensity you have to think about as a provider, right? What did she was saying?
Mm-hmm.
She could explain it to me just as fluid as I could tell someone my name. But when I had to apply it through the lens of the coding, I'm like, I get it. I'm not saying this was a low level patient from an acuity standpoint, not qualified to do that. But when I look to qualify this as a critical care case for coding purposes,
Mm-hmm.
even if I didn't question the condition, because the guidelines they give us is a condition that has basically the potential to deteriorate such that there is a vital
Mm-hmm.
organ system failure, right? So I go
Right.
to the second part, and that's where we get stuck because when it's abnormal lab values and things like that, where I think I don't know the normal hematocrit, and kids make it even difficult because
Oh yes.
temperature in a kid versus a temperature in an adult might look different and be less
Absolutely.
worrisome. So it's so much more clinical for the condition criteria. But when I look at what did we do, the heroics, it was not there. So when I
Mm-hmm.
actually, wanted to support the physician, so I actually queried that directly to the AME, even though I thought it was questionable. And they came back and said, that's not the intention of these codes, right?
Mm-hmm.
No, that's not critical care. May be a higher level of care based on the amount of work that you did, but it does not pass the critical care test, if you would. So
Mm-hmm.
when I think about how often we see conditions, I think for coders, the absolutes you won't have them questioned, right? If I see the failures, especially the ones in the guidelines, the heart, the liver, the lung, the renal, those are pretty straightforward, and I think we see the conditions that tie directly to them. What gets harder is some of the values, some of the things you see very easily looking at that patient as an experienced
Mm-hmm.
emergency room physician and say, absolutely, like any doctor looking at this would know it's critical, but makes me
Right.
say,
That,
is
that
that
has
critical?
you has to take a pause to determine, is this critical care or is this routine care?
Exactly, and that's a great segue for kind of what I look for with the water of life session that I thought about. We see fluids
Mm-hmm.
very often in the emergency
Correct.
room. And I couldn't put an exact number, but if I go back to my ED days, for every patient that came in pulling the traumas out, we might see them easily in like 70 or 80% of the cases. So much
Absolutely.
fluid. So
Absolutely.
70 to 80% of the cases aren't necessarily critical, but are there times when fluids and their different variances can be really all you need to do to turn that condition around that's looking like it could go critical or fatal or cost the patient their life? Can you tell me
Absolutely.
about what time fluids might be used and like tell me what kind of fluids perhaps you might use as a critical care and emergency room physician?
Absolutely. So one of the most common fluid that's used is the infamous normal saline. So, you'll hear the NS is another term for normal saline that you'll see on the chart. And normal saline, it's isotonic, and it's used because it's similar to the body's composition, and it can be used to hydrate, regular rehydration, and also for resuscitations. During regular rehydrating processes, such as if someone's coming in with vomiting, diarrhea, and their vital signs are, normal or just a slightly abnormal. For example, if their heart rate's a little elevated, which is normal heart rate, you're looking anywhere between 60, and we're saying 60 because half the people are on beta blockers. Pardon me. Half people are on beta blockers, so their heart rates are between 60 and 100, and that's considered normal. Even though I know the book would usually say between 80 and 100. But like I said, half people are on medications that makes their heart rate in the 60s. And an additional normal heart rate in the 60s would be for an athletic person because they're so effectively pumping. So they're, a very athletic person who runs and exercises a lot, a normal heart rate for young adults in the 60s is normal in that range. So once the heart rate goes above 100, then it's considered to be tachycardia, and that's considered abnormal. So if someone is dehydrated, the volume is lower, and therefore the heart is pumping faster, and then you might see the heart rate being a little bit over 100. 100 to 110 or so, you said, okay, that patient is dehydrated. So resuscitating them or rehydrating them, I should say, with IV fluids is something that you'll see. So you might see someone get like 1 liter of normal saline because of the fact that they have what we consider gastrointestinal loss, which is like GI tract. I consider the GI tract anything. I call it from the rooter to the tutor. Anything as soon as you put it in until it comes out. That's the GI tract. So if you're losing things from the top or from the top is vomiting, from the bottom is this diarrhea. You can become dehydrated and then you rehydrate with IV fluids. So you have different categories of dehydration. So those are the mild ones where you're mildly dehydrated and your heart rate, starts to go up. Now, when you have excessive dehydration, for example, other ways that you can find out for like excessively dehydrated persons, that person who's been vomiting consistently, refusing to go to the hospital, trying to do it at home, and then their heart rates are in the 130s. So it's no longer just one, 05, 106 or so. They're in the 130s or 140s, and you might even see other documentation such as the mucous membrane, which is one of the things that their mucous membrane is dry, they're tachycardic, and you might even see their mentation. They're starting to become confused. So in that respect, you can give normal saline, but the amount of normal saline will usually be higher. So they will usually not be resuscitated because at this point you're trying to resuscitate them, not just rehydrate them. You're not going to just use just one. You might have 2 or more liters of normal saline in order to resuscitate that person. And so at that point, that's now critical care because you've had, you said like an eminent organ system failure, which is what the brain. And you can tell why are we having a possible organ system failure because they're altered, they're confused. So that's showing that there's an system, which is the brain, the neuro system is being, that's a possibility that you're having a failure or a disruption in that system. In addition to the kidneys, you might see that on the lab work. The dehydration is so bad that it's causing kidney failure. And then the skin, which is another organ. We talked about the mucous membrane. Some people might talk about, describe the turgor in the skin, the tenting that's noted on the skin, which is essentially a tenting, is if you have your hand out and you're just looking at your skin of your hand, and if you pinch it, you'll notice that the skin comes up. And if you are regularly hydrated and you let go, the skin just it returns to its normal form. With tenting, if you pinch the skin, it stays up and it looks like a tent. So that's what that tenting is. So it looks
Got
like a
it.
tent. So that's a form that there's excessive dehydration that's going on. So that's one way in where you will resuscitate with IV fluids. And you're just using normal saline, because that's essentially that person has lost the fluid and they need it to return.
This is a good moment to pause. Dr. Beckford just gave us some really good information for us to look out for as we examine evaluation and management notes that may factor critical care. First thing that jumped out for me is the amount of fluid. So based on whether they're trying to hydrate or rehydrate, the amount of fluid might be different. In a case of dehydration, we might see 2 or more liters of fluid. So this is where, as coders, I don't think we pay a lot of attention to the volume of fluid administered to paint the picture on whether critical care is there. Also, we can't stop at fluids. So when we look at history, our history may support something like a patient who has an alteration in mental status. That's something that might be, again, reported based on either the patient themselves or a person who has experience of the patient. From an examination standpoint, we would find things in our ENT exam as far as dry mucous membranes. Physician may also document objectively, this is what the provider sees, an alteration in mental status. The skin or integumentary exam would show things like tuger or tenting, again, evidence of dehydration as she beautifully explained. Our mucous membranes, we'd need to look to our ear, nose, and throat examination because that's typically where they go to find that data, and again, would be evidence. This is important because when it comes to the failures, as I stated before, the failures are very easily captured diagnostically. Like we see a failure, it's in the guideline, it's almost like a check system. But if we had a patient who maybe expired before it resolved or was transferred and taken over by another provider before it resolved, and maybe we only got to treat the patient for the first 40 minutes of care before they were transferred because it was evident that this patient was going to be admitted. Diagnostically, we may not have the final diagnosis of the failure yet, but this is where we would use our appropriate, in the ED, 99291 code, report the diagnostic symptoms of heart rate increase, ensuring that you code this with an R code as opposed to an I code. If all you have is something like tachycardia documented, we're saying, hey, the heart rate's just higher, as opposed to indicating that the patient has a conduction disorder, which is what the I codes say. Dry mucous membranes, we could report that. Alteration in mental status, which we have a code for, and skin, tenting, or tuger. If you can't find something there, you can say abnormalities in the skin or symptoms involving the integumentary system.